Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. So this week's case is an 85-year-old male with a history of type 2 diabetes, coronary artery disease, status post stent placement, and COPD that presents with altered mental status. His presenting EKG is shown here. Before we get started, let's review the approach we've been using to interpret EKGs. So notice that we have the patient's clinical presentation and then the EKG below. On the right side of the screen, you'll find a list of different parts of the EKG that we'll go through before making our final interpretation. First, you'll see that we have the regularity, okay? And with the regularity of the rhythm, we want to see if we're dealing with a regular or irregular rhythm, and then if it's irregular, are we dealing with a regularly irregular rhythm or irregularly irregular rhythm? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we'll look at the rhythm origin, that is, where is the rhythm actually starting from within the heart? Then we have to determine the ventricular or Qrs Axis, which could help us with our differential diagnosis. Then there's atrioventricular, and intraventricular conduction, looking at if this conduction is prolonged in any areas of the heart. Then we'll look at the waveforms, which would include the waves, the segments, and intervals. And lastly, anything else, meaning is there anything else that we've missed or still need to mention at this point, such as abnormal R wave progression or an abnormal transitional zone in the precordial leads. After that, we'll use all the information that we've gathered to make a final interpretation. Now, I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go over it together. So as we mentioned, we have an 85-year-old male with a history of type 2 diabetes, coronary artery disease, status post stent placement, and COPD that presents with altered mental status in this EKG. So let's walk through it. So first, what is the regularity of this rhythm? Well, on first impression of the EKG, you probably notice that this rhythm appears to be quite regular. In fact, this is what we call a regular rhythm. Okay, so regularity, this would be considered a regular rhythm, okay? And remember, one of the easiest ways to do it, okay, and you can look at any interval, but the easiest one is we can look at this rhythm strip of V5 down here, okay, and look at the R wave to R wave, okay? Remember, the R wave is the first positive deflection after a P wave, and this R wave to R wave is called the R to R interval. And we want these intervals to be consistent throughout, okay? Meaning that we want this R to R interval to be similar to the one that follows it. So from this wave to the next one, okay? We want these distances between to be the same, and the same thing of the one that follows, okay? So all of these, if you were to measure out all these R to R intervals, okay, between all of these different R waves, they would all be the same throughout. So because of that, that's what we call a regular rhythm, okay? So what did you get for the heart rate? Well, there's a couple ways we can calculate it because we have this regular rhythm, okay? Now, one way we can do it, all right, and I'll erase this so we can clear up some space. So remember that we know the EKG, this is a standard EKG, so it represents 10 seconds in duration. So from beginning to end, this is 10 seconds. If you multiply 10 seconds by 6, that's 60 seconds, which is 1 minute, okay? So that means if we count the number of complexes going across, whether it's P waves or QRS complexes to get an atrial or ventricular rate, respectively, you can multiply that number by 6 and get an estimate of the rate, all right? So let's do that here. So we'll do a ventricular rate, okay? Because the QRS complexes are pretty easy to make out here. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and let's say 13. Okay, you can see that one coming out there on the end. So what you would do here is 13 times 6, okay, and 13 times 6 is 78 beats per minute. Okay, so what we got here was an average, okay, so 13 times 6, we'll write it here for you, is 78 beats per minute, okay? And because we're dealing with a regular rhythm here, we can also use another way to find this rate, okay? And what you do is you want to find a complex that falls on one of the thick lines, okay? So let's say we use this one here, okay? Notice that you can see that it's clearly falling on that thick line, so this red thick line, all right? And then we want to find the next R wave. Okay, here's the next R wave, and we want to count the number of thick lines between them. Okay, so this would be 1, 2, 3, 4, 5. Okay, so it's much less than 5, and it's pretty much 4. Okay, if you look from this one to this one, it is about 4. So what you would do here is 300 over 4. okay, and that gives you 75 beats per minute, okay, and the actual average rate that the machine got was in fact 75 beats per minute, okay, so you can see both ways to calculate this are pretty close, okay, and remember, you don't really want to use the second method if you're dealing with an irregular rhythm. Stick with that first one, okay. So if you have AFib, use that with those irregular rhythms. All right, so let's look at the rhythm origin. Well, we have narrow QRS complexes, so we must be dealing with a supraventricular rhythm, okay, meaning a rhythm that's originating from above the ventricles. We can also make out clear, defined, similar shaped P waves in each lead. So now we have to ask ourselves, are we dealing with sinus rhythm? So let's see here, okay? So there's a few different things you want to look at to make sure you're dealing with a sinus rhythm, or a rhythm that's originating from the sinoatrial node. So we'll erase some of this here to make some room. Remember, if we look at our heart using this box diagram, this is our right atrium, left atrium, okay? Right ventricle and left ventricle. The sinus node is over here, okay? We have our intranodal pathways that come to our AV node that's also in the right atrium, okay? You have a Bachmann bundle that depolarizes the left atrium. Then you have the His bundle that splits off into a right bundle branch, okay? That depolarizes that right ventricle, all right? And then we have the left bundle branch that splits off into a left anterior fascicle and a left posterior fascicle, okay? Now both these fascicles and the right bundle branch then end up in the ventricular Purkinje fibers that innervate the individual cardiomyocytes. Okay, so when we talk about sinus rhythm, all we're saying is that the rhythm is originating from up here in the sinus node. Okay, so if you look at the normal conduction, it should be heading in this direction, meaning that if we put our right atrium over this, okay, imagine this is our right atrium, okay, and then we have our sinus node here. Conduction should be heading in this direction, okay? The normal P wave axis is actually between 0 and positive 75 degrees, okay? So that's one thing to note, all right? So when we see that, and if you know where your leads are placed, this is where lead 1 is, okay? Lead 2 is here at positive 60. Lead 3 is here. This is AVF, okay? AVR is here. In our precordial leads, we have the horizontal plane where we have V4, V5, and V6. So if you see that green vector that's heading in this direction, okay, all these leads that it's heading towards will have upright P waves, okay, in sinus rhythm. And those that are, because the sinus impulse is moving away from AVR, we will see negative P waves in that lead, okay? So what we want to see here, and why are we looking at P waves? Well, that represents atrial depolarization, and that's where the sinus node is initially firing from, within the atria, okay? So we want to see upright P waves in leads 1, 2, AVF, V4 through V6, those left lateral leads. So let's take a look if we can see those, okay? So here's lead 1, okay? You can make out the P waves. They're hard to make out, so I'll erase that so you can see that. But you can clearly see that there is a P wave there, okay? All right, if we look at lead 2, here's a P wave, there's another P wave, and another, okay? AVF is here. You can see those are the P waves, and there's one right there. And then if we look at those left lateral precordial leads, which are V4, V5, and V6, a little hard to make it out, but you can see one that's shown up there, maybe a little more clear there, okay? And if you were to measure them down, they should be appearing right here, okay, but harder to make out, a little easier in V4 to see, okay? So you do see those. And then in AVR, we want to see an inverted P wave, so here's AVR, and we can see these inverted P waves occurring, okay? Another thing you want with sinus rhythm is that you want those P waves in each lead to have similar morphology, okay? So it seems easiest to make them out here in AVF or in lead 2, okay? We can come down here to the rhythm strip. Notice that these P waves all have the same morphology, okay? So all the same morphology, and notice that there's always one P wave for every QRS complex, okay? So we always have that P wave preceding the QRS complex, and that's a 1-to-1 ratio. So if you meet all those criteria, and we do here, we in fact are dealing with sinus rhythm, okay? So our rhythm origin is from the sinus node. So this is a sinus rhythm going on. Now let's look at the ventricular or QRS axis. And you should have gotten a normal ventricular axis. The actual axis here was positive 61 degrees, okay? So it'll be normal, positive 61 degrees, and let's see why, okay? So I'll erase this down here. All right, and hopefully that makes sense why sinus rhythm is present. Okay, that's an area that I think most people don't understand. Okay, so hopefully if you can get that, it's not too difficult, and you can share that with some of your friends. So now with the ventricular access, here is 0 degrees. And this is where lead 1, the positive end, sits. This is positive 90 degrees. Okay, AVF is down here, that positive end. This would be plus or minus 180 degrees. And then we have negative 90 degrees here, okay? And when we talk about normal access, remember normal access, the physiologic normal access lies between negative 30 degrees, okay? And then positive 105 degrees. Remember, as you get older, so as an infant, you have more of a rightward shift, and this would be more right axis deviation, okay? This is that normal access range that we talked about, okay? So when you're younger, you have more of a rightward shift, and eventually you'll go more leftward with age, okay? As the left ventricle starts to take over early on in life. So this would be a leftward shift, okay, or left axis deviation, and this quadrant here is what we call extreme axis deviation. So in this case, we want to first look at leads 1 and AVF, okay, there's multiple ways you can do this, but looking at lead 1 and AVF is a pretty easy way to do it, and it gets an accurate result. So here's lead 1. Notice that these are positive QRS complexes, meaning that we're going towards the positive end of lead 1, okay? And then if we look at AVF, this is AVF here, notice again we have these positive upright complexes, meaning we're going towards the positive end of lead AVF. That puts us in this region, okay? So automatically we can tell that we're within normal access, okay? And then if you were to put lead 2 here, which we don't have to, but just so I can show you, there's lead 2 that sits at positive 60 degrees, okay? Lead 2 again has an upright, almost all monophasic R waves, okay, in that lead, so you can see it's heading in this direction. Remember, the axis here was positive 61, which makes sense, okay? So this is a normal ventricular access. Let's move on to atrial conduction. Well, typically we look at leads 2 and V1 for P wave or atrial abnormalities, as they appear to be the most evident in those leads. Well, in leads 2 and V1, we don't reach the P wave amplitude for right atrial or left atrial enlargement. In addition, the total duration of the P waves here in these leads appear to be within normal limits, okay, and usually want that to be less than 120 milliseconds, or 3 small boxes, okay? So in this case, we do in fact have normal atrial conduction. How about atrioventricular or AV conduction? Well, in this case, we're looking for the conduction delays as the impulse travels between the atria and the ventricles. Because the majority of the PR interval represents AV nodal conduction, that's where we look. The normal PR interval in adults, we're dealing with an adult here, is between 120 and 200 milliseconds, or 3 to 5 small boxes. However, in this case, the PR interval appears to be a little longer than we would expect. In fact, it was measured at 286 milliseconds, which is well beyond the upper limit of 200 milliseconds, okay? So this suggests an AV block is present, okay? And more specifically, we have a first-degree AV block because there's no evidence of any dropped beats that we saw. Remember, there's always a P wave for a QRS complex, no drop beats, and there's no change in the PR interval that we'll see here, okay? So just so you're aware, let's erase some of this to clear it up, okay? And we're looking now at AV conduction. So where we want to take a look is at that PR interval, okay? So what is the PR interval? Let's just draw that out. So this is our complex. Imagine this is your P wave, this is your QRS complex, and your T wave, okay? And when we look at the PR interval, it's from the beginning, the start of the P wave, up until the start of the QRS complex. That's our PR interval, okay? Don't confuse that with the PR segment, which is from the end of our P wave up until the beginning of our QRS complex, okay? So normal PR interval from this point to this point is between 120 to 200 milliseconds, okay? In this case is greater than that 200 millisecond, that upper limit of normal. All right, so let's take a look here. Where can we see an easy way to kind of point this out? Okay, so let's look at this one right here. Okay, let's look here, and we're looking from this P wave up until the beginning of this QRS complex. Okay, so notice that within here, okay, you already have more than 200 milliseconds. Remember, between these thick lines, so from one thick line to the next, that represents 5 of the small boxes, which are all 40 milliseconds each. So if you multiply 40 milliseconds by 5, that's 200 milliseconds, okay? So if it's beyond that, then we start thinking of these AV blocks, and we can clearly see that these intervals are all greater than 200 milliseconds, okay? So in this case, we are dealing with a prolonged PR interval, okay? And the actual interval here was 286 milliseconds, okay? So what we consider this beyond 200 milliseconds is that first degree AV block, okay? Because there's no drop beats, and you would see all these PR intervals are remaining the same length, okay? So this is what we'll talk about this in a bit, is first degree AV block, okay? All right, next we have intraventricular or IV conduction, okay, and this is where we look at the duration of the QRS complexes. Normal QRS duration is between 70 and 110 milliseconds, okay, or about 2 to 3 small boxes. Some may say consider that upper limit to be 120 milliseconds, okay. Anyways, the main thing here is that we're with intraventricular conduction is seeing whether or not the QRS interval is prolonged. On this EKG, we can see that we have narrow QRS complexes that appear within normal limits. In fact, the QRS duration here is 86 milliseconds, which helps to confirm that IV conduction is normal on the EKG, okay? And again, what we're looking at here is the width of the QRS complex, so from the beginning of it until the end, okay? Right up to the end. That's our QRS duration or interval, okay? And this one was normal, all right? And it was, what did we say? It was 86 milliseconds, okay? So below that 120 millisecond range, okay? Now, how about the waveforms? We already discussed the P waves, okay? So it seems like we may have actually here some abnormal Q waves or QS complexes. Did you notice those in V1 and V2? This may suggest possible prior septal infarct, maybe even involving the anterior portion of the left ventricle that we'll soon see, okay? So what I'm talking about here is, if you look at leads V1 and V2 are right precordial leads, all right? These complexes here, okay? You can see some of these complexes actually may have a small R wave, but it's really difficult to make out, and that's why we'll call it possible, okay? So these are likely deep Q waves, okay? And we would call these QS complexes or deep abnormal Q waves, okay? So that's one thing we'll know here are these deep Q waves, all right, or these QS complexes that are certainly abnormal, okay? And we'll see a few things that will also kind of point to this possible infarct. So normal T waves are here, okay? They're asymmetric. They have a slow upstroke and a steeper downslope. The PR segment does not seem to be significantly depressed or elevated throughout the EKG. The PR interval, remember we mentioned, was prolonged. There are no dropped beats, okay? The ST segment does not appear to be significantly depressed or elevated anywhere. The QRS interval, we said, was within normal limits, all right, 86 milliseconds. The QRS amplitude does not seem abnormally increased or decreased throughout the EKG. And lastly, with the waveforms, the QTC interval here is normal. It was calculated to be 393 milliseconds. Remember, normal QTC interval in males is less than 440 milliseconds, and in females is less than 460 milliseconds. So just remember, the QT interval is from the beginning of our QRS complex until the end, okay? That's the QT. When we talk about the QTC, that's the corrected QT interval that adjusts for heart rate. One of the most common formulas we use is the Bazet formula. Usually the EKG machine will have that calculated for you, okay? So males less than 440 milliseconds, females less than 460 milliseconds, all right? Our gentleman here's was 393 milliseconds. So overall, the only major waveform abnormalities that we noted were those abnormally deep Q waves that we saw in leads V1 and V2. Okay, so we call those contiguous leads because they are next to each other within the anatomic region of the heart. All right, so is there anything else we're missing here? Well, how about the R wave progression in the precordial leads? Normally, the R wave amplitude should progressively increase from leads V1 through V5. In this case, it seems like we don't actually see a true R wave, okay, until V3 in the precordial leads, which is not normal. This diminishment in the anteroseptal forces may suggest a possible prior anteroseptal infarct that we mentioned earlier, okay? So this is something important, and it can kind of help point you to these may actually, in fact, be real Q waves of significance, all right? So notice we were talking about these Q waves, all right? And when we talk about R wave progression, we want to see an R wave from V1, okay? So the R wave should increase in amplitude from V1 through V5. Okay, we can barely make, and this is likely not an R wave here in V1. Okay, and the same thing in V2, so no R waves already, and then you finally get a true one here in V3. Here's an R wave. Okay, and you can see it getting steeper and steeper with the leads that follow. Okay, so this is what we call an abnormal or poor R wave progression. Okay, so we will just say poor R wave progression. Okay, and notice that the poor R wave progression is happening in this region. Okay, and then all of a sudden you get a spike in that, and that again may point to that anterior portion of the left ventricle that may also be involved in a prior infarct. Okay. Now, the transitional zone is something else we should look at in the precordial leads. And in this case, it appears to be between leads V4 and V5. The transitional zone is simply the precordial lead where the QRS transitions from being mostly negative to mostly positive, with the actual transition area being where the QRS complex is isoelectric. Okay, and we oftentimes won't see that on the EKG. Now, normally the transition zone occurs between leads V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. If it occurs after lead V4, then we call it a clockwise rotation or late transition. Therefore, because the transition in this case occurs between V4 and V5, which is after that V4, we call this a clockwise rotation or late transition. Okay, so clockwise rotation, or you may hear it called a late transition. Okay, both meaning the same. And remember, what we mean by the transitional zone is it going from mostly negative. So notice our complexes here are mostly negative. Okay, here's V2, same thing, mostly negative. Same thing in V3, mostly negative. All right, and if you were to take these complexes, you would still see that it is still like a little more negative in this case. Okay, so the transitional zone occurs between V4, and then you can clearly see these are mostly positive complexes in V5. So it's between here, V4 and V5, okay? And that's what we call a clockwise rotation or late transition. Normal transition should be between here, V3, and V4, all right? And one thing I want you to keep in mind is that with R wave progression in the transitional zone in the precordial leads, this is highly dependent on lead placement, which is still an imperfect science today. Anyways, what's our final interpretation? Well, we have a regular rhythm with sinus origin, okay, in a rate of 75 beats per minute. The ventricular axis is normal. Atrial and intraventricular conduction are normal, although AV nodal conduction we said was prolonged, all right, with that PR interval being longer. We also notice these abnormal deep Q waves in leads V1 and V2, along with poor R wave progression and a late transition in the precordial leads. All of these are not unrealistic in a patient with coronary artery disease status post-stent. And it wouldn't be surprising that the patient had an anterior or a prior anteroseptal infarct that he had, and maybe that region was actually stented. So our final interpretation, when we just look at the EKG here, is sinus rhythm with first degree AV block and a possible anteroseptal infarct that we cannot rule out. Now, when compared to a previous EKG, the only changes that you can see are premature supraventricular complexes that are no longer present there, okay, or at least in this EKG. So you always want to make sure that you look back at an old EKG if it's available to see if there's any changes between the most recent one and the past recording. All right, so let's write our final interpretation here. Okay, so we said that we do have sinus rhythm present, so we have a sinus rhythm, okay, with first degree AV block. All right, we also said that we could not rule out an anteroseptal MI, so we'll make note of that. So we cannot rule out an anteroseptal MI. Okay, we saw those with the deep Q waves in leads V1 and V2 and that poor R wave progression. Okay, and then when we compare it to the previous EKG, and that's something I always want you guys to do, is that the premature supraventricular complexes are no longer present. Okay, so the premature supraventricular complexes are no longer, okay, present. All right, and hopefully that makes sense. So in conclusion, our 85-year-old gentleman with a history of type 2 diabetes, coronary artery disease, status post stent placement, and COPD that presents with altered mental status has an EKG showing sinus rhythm with first-degree AV block, and we cannot rule out an atrial septal infarct. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.